Hey everyone, welcome to Ward 101, where we talk about medicine beyond textbooks. So, today I wanted to share a real patient case that shows why scrotal pain doesn't always follow the textbooks and how a general practitioner can manage it safely in his outpatient department and then refer him to the emergency department or the respective department. So, this was a patient, a cook, who came to the hospital with the swelling in his right testis since 3 days. Now, he noticed it while cooking and it was gradual. So, it was not a sudden onset, it was not exercise induced, not because of some vigorous activity, just gradual discomfort that was radiating to the inguinal region. He also had fever and runny nose 3 days ago when asked for the history. So initially it sounded like epididymitis. But when we examined him, something didn't fit. The pain was diffuse and it was not posterior, so it's not epididymitis, which already raised a red flag. So we tried gently rotating the testis to the midline and his pain immediately improved. Now keep this in mind that not every patient will let you rotate his testis depending on the intensity of the pain. So when we rotated his testis to the midline, the pain immediately improved, which is a classic clue for torsion, even if the presentation is not textbook. We wanted to manage it with analgesia. He was allergic to diclofenac, so we used a safe alternative. In such cases, you can use ibuprofen or a paracetamol or a tramadol if NSAIDs are not an option. Then we also collected a midstream urine sample to rule out infection because a proper collection is important to avoid contamination of urine and to reduce discomfort. Then we applied a T bandage, scrotal support, and then referred him urgently to a major hospital for definitive care. Now, this case is a perfect example of why textbooks don't always prepare you for real life. Torsion is described as sudden severe pain, but real patients can have gradual or delayed pain. When you sit for exams like Step 2 CK or when you're solving questions from U World, they always emphasize that testicular torsion is always sudden in severe pain that is due to some vigorous activity, but real patients can have gradual or delayed pain. Now, pain distribution matters more than the onset. Epididymitis usually causes posterior scrotal pain, while torsion causes diffused pain anywhere in the scrotum. Relief of the pain after medial rotation was the strong clue. But always remember that even if the patient's pain improved, torsion can reoccur anytime. So referral is still mandatory even after managing the patient. Other red flags to watch for includes swelling, nausea, vomiting. This patient had diaphoresis or any delayed presentation beyond 6 hours because that increases the risk of testicular torsion. Yes, this patient came after 3 days, so he was at clinical risk. Now, the clinical pearls for this case are that viral symptoms or a misleading history can make torsion tricky. So, subtle exam findings, careful reasoning, and attention to pain location are essential. Always examine both the testes, provide safe analgesia, apply scrotal support, and never delay the referral. If you want to see exactly how we make a T bandage step by step, comment below and we'll do a demo in the next video. Also, have you ever seen a patient with an atypical torsion? Share your experiences in the comments and we love to hear about it. Now, this is Ward 101, where we teach real practical medicines beyond textbooks. See you in the next video.